Hi there, this is Marielle Concepcion, your host of the My DPC Story podcast. Have you or someone you care about ever been burned by the U.S. healthcare system? If so, you are listening to the right video, because if you are listening, chances are the answer is yes. But the U.S. spends so much on healthcare. Why are so many Americans affected personally and especially financially by the healthcare system? Shouldn't that mean we have better healthcare access and treatment options? Shouldn't it be easy for us to be able to see our doctor when we need to instead of turning to the ER or urgent care? Historically, it's been seemingly impossible to answer these questions. But now that is changing through the direct primary care movement. This video that you have tuned into will bring you into the world of direct primary care and show you how physicians all over the country are changing the way they practice so patients from all backgrounds get the high quality care they need and deserve, which makes for both happy patients and physicians. Learn even more by subscribing to the My DPC Story YouTube channel. Find us on all major podcast platforms. Find us on socials at My DPC Story and at mydpcstory.com. There you can find resources including how to find a DPC doctor near you, conferences about DPC, DPC startup guides and advice, a store with DPC swag, and even a mapper showing where podcast guests are practicing. Thanks for tuning in to hear about this powerful movement. Now, on to the episode. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care means individual, attentive care with longer appointments and better access to a provider than most people have in the community.
And this should be offered in some way to all patients, no matter their ability to pay.
I am Dr. Erin Kiesel.
And I'm Dr. R.J. Heck of St. Luke's Family Practice.
And this is our DPC story.
Dr. Erin Kiesel earned her BS from Santa Clara University in 1994, where she graduated cum laude and was part of the Alpha Omega Alpha Honor Society. She then went on to earn her medical degree from Midwestern University Chicago College of Osteopathic Medicine in 1997. She completed her family practice residency in Modesto, California from 1997 to 2000, and then she went on to complete a fellowship in faculty development at UC San Francisco from 2011 to 2012. In addition to being awarded the Teacher of the Year Award by the Stanislaw Health Foundation in 2012, she continues to serve as a clinical professor of family medicine at the UC Davis School of Medicine since 2000. Her special interests include pediatrics and women's health. She is married to George and they have 4 children. Dr. R.J. Heck earned his BS from the University of Arizona in 1987, where he graduated summa cum laude and was awarded the President's Award for Excellence. He continued at the University of Arizona, where he earned his medical degree in 1991, and, like Dr. Kiesel, he too trained in Modesto, California, completing his family practice residency from 1991 to 1994, and achieved the Excellence in Resident Research in 1994. He has 2 sons and has volunteered with Liga Internacional, where they do mission trips to Mexico. Together, they are part of the team at St. Luke's Family Practice in Modesto, California. Dr. Robert Forrester, who has recently retired, and Dr. Heck opened St. Luke's in 2004. Welcome to the podcast, Dr. Kiesel and Dr. Heck.
Thanks for having us.
Yes.
I want to start by reading the mission of St. Luke's. And that mission is to establish a self-sustaining nonprofit organization for the delivery of free outpatient health care consistent with the Catholic tradition to uninsured persons ineligible for government programs. Now, with that statement, what does this mean or tell us about your practice?
I will take that one because I was around at the very beginning of it. But when Dr. Forrester got this idea, it was really a gift of the Holy Spirit. And it was to take care of a small number of people who would be donors to a practice that then would allow us the time, because it was just a small number of patients, it would allow us the time to take care of uninsured people for free. And this was before the Affordable Care Act. And so there were lots of people who were in that notch group who didn't have their own insurance, didn't qualify for Medi-Cal. That number has dropped quite a bit with the Affordable Care Act, but there's still a huge number, particularly in the Central Valley, of people, of human beings, be they American citizens or not, who don't have access to health care. And so our goal has always been to reach them and at the same time take great care of a small number of people. We call them the goose that lays the golden egg, the benefactors who contribute to the practice each year and keep us running.
Thank you for explaining that. And on that note, can you give us a little bit of a breakdown with regards to your demographics?
For the most part, on our recipient side, I think we're probably in the range of about 2/3 Latino, maybe even closer to 70%. And of those, I would say about a good 2/3 of them are Spanish-speaking only, or at least primarily. On our benefactor side, mostly people who are more affluent and older. So our uninsured side can be all ages, rarely kids, because most times kids, whether or not they have papers, are eligible for some form of Medi-Cal. But on the adult side of those uninsured patients, that was the demographic I was talking about with our uninsured folks. And for the benefactors, I would say people who are affluent, and for the most part, my practice has matured more. And so all of them, I think, are now at least over the age of 40 and have kids. And I would say a huge number, better than 50% of them, are Medicare age and older.
Can you explain to the listeners what is a benefactor and what is a recipient?
Erin, you want to do that? Or?
Sure. So I would say a benefactor is a patient that comes to us and has the ability to pay for their care. We have an annual fee that they pay. It's based on age. To a certain extent, it's based on how much care they need. Patients that are older and that require care at home or care in a nursing facility or home care are going to be a little bit more expensive. But in any case, they pay an annual fee. With the money that is left over of what they're putting into their care, we are able to take care of another subset of patients that are called recipients that are completely uninsured and are not able to pay at all.
And for the annual fee, do the benefactors determine how much they donate to the practice as an annual fee, or how does that work?
No, there is a set fee, and it's based on age. So I don't have the breakdown in front of me, but it is a set fee. So they know in advance how much they're going to pay. And as we take care of them through the year, we do keep an accounting of their visits and the time spent. And then at the end of the year, those amounts, which are assigned a value, like an RVU value, if you will, just like as if we were billing insurance, but we don't bill insurance. That amount is subtracted off, and whatever's left, the benefactor is able to write off their taxes as a donation because we are a nonprofit.
It's very unique in terms of how to approach providing care for all in the DPC umbrella. Because St. Luke's has both benefactors and recipients, how do you guys get the word out in the community that you do have care for anybody who might need care?
We have some different approaches for that. For the recipient side, of course, word of mouth has always been on our side. Local churches know about us, emergency rooms, urgent care centers, the Medi-Cal offices where patients sign up for Medi-Cal has our information as well. We're also starting a social media campaign, which of course social media is available to anyone. And some of the local county clinics also know about us. And so when patients come in and they're completely uninsured, they send the patients our way as well.
I want to go into more detail with regards to when a patient, whether they're a benefactor or a recipient, can you walk us through how it looks in your practice when they wish to join?
Uninsured patients when they hear about us, it used to be we'd have them come in and see us, and we'd see them the first time, no matter what their payer status. Now with COVID, we're requiring everybody to call and make an appointment. But we will see them the first time and figure out what their payer status is. Ahead of time, what happens, the front desk nurse asks them, do you have insurance? And if they already have Medicare or Medi-Cal and they want to become a benefactor, we will offer them that. Many people choose to do that, others don't. If a person wants to be a benefactor, we've found that our greatest source of referrals in the past has been other benefactors. We hope or anticipate that will change with our social media campaign, that will reach a newer, younger demographic. But up till now, if a person expressed interest, we invited them in and scheduled them for a meet and greet appointment where they just got to sit down with the doctor and talk about the philosophy of the practice and what would be done and what could not be done, and all of the details. A half an hour out of our day is easy in terms of selling. It's an easy payoff, because most of the time when a person can sit face-to-face with a doc for half an hour and get details about a practice, they love the place. That's how we approach those two. And as Dr. Kiesel said, marketing, we had not expended a whole lot of effort into that in the past, because our greatest source of referrals for benefactors was word of mouth. But as we were trying to ramp up, as Dr. Kiesel joined our practice and we had a third doctor, we discovered social media is a huge untapped area that we needed to get into more. And so just toward the end of 2020, we were starting, actually the middle, we were starting to get into tapping into that resource. And so we'll explore that further and anticipate further growth in the future.
Stay with us. We'll be right back. My DPC Story just hit 100,000 downloads on Apple Podcasts alone, and we could not have done it without our amazing listeners. So to thank you and to celebrate this milestone, we're giving away an incredible DPC Summit prize package for the DPC Summit happening in Minneapolis this summer. The prize includes My DPC Story swag, and on top of that, the prize also includes a ticket to the DPC Summit. Check out my interview with Dr. Jeff Davenport, where you'll hear more details about the summit. To be eligible for this giveaway, all you have to do is first rate and review My DPC Story on your podcast listening platform. Pro tip, if you rate My DPC Story with a 5-star review, it helps the visibility of the podcast and it helps others to find all these DPC stories. Number 2, take a screenshot of your review and email it to support@mydpcstory.com. You'll find that email in the show notes as well. And third, make sure you're following My DPC Story on all your social media platforms: Instagram, Facebook, TikTok, YouTube, LinkedIn, and Twitter. All the social links are at the bottom of mydpcstory.com and also in our show notes. For bonus points, share both this episode and the My DPC Story posts about the DPC Summit with your community. The winner will be announced in a future episode, so make sure you tune in to find out if you'll be heading to the summit. If you've already purchased your ticket and you're the winner, My DPC Story will send you a check for the price of your ticket. Thank you for listening to My DPC Story, and best of luck. When you mentioned social media, what avenues of social media have you guys targeted?
So far, we've mainly just started getting a Facebook page together, and Instagram have been our two main platforms. We've had a little rocky start with that, and we're going to get a little help getting that going, but that's where we're starting, basically.
And when you mention a little help, are you guys looking to hire a person in marketing, or are you guys going to organize the social media campaign yourselves?
Well, we have a consultant right now that's helping us with that, and I think they're going to help us just launch it. But then myself and our physician assistant is pretty good at social media type stuff. And so I think the two of us are going to try to just do it on our own, or possibly use perhaps like a college student that's interested in marketing that might just help us with just putting content up frequently to keep up with it if we get too busy.
Absolutely. And that's actually an untapped resource that a lot of docs don't necessarily think about. If you have a community college or university or something where you can reach out to a member in the community who might be interested in having your clinic or your DPC as their quote unquote project to work on. I've seen doctors use that successfully to develop a marketing campaign that they may or may not continue on their own after it's fully developed. So that's wonderful that you guys are building that from the ground up. And it will be interesting to see, like you're talking about, the targeting the younger population. It'll be interesting to see how that impacts your guys' demographics, because with the pandemic, it's our way of communicating even more so than it was in the past.
Exactly.
It's become everybody's way of communicating. Even my 80-year-old mother now has become an expert at FaceTime and Zoom.
On the opposite end, I have a 3-year-old who knows what FaceTime is compared to Zoom. So I definitely hear you there. Is there any other way that you guys have been affected by the pandemic? Because you were mentioning how the way patients are scheduled is different, and that's absolutely seen in a lot of clinics where you have to call rather than sit in the waiting room, or you have to be screened before entering a clinic.
Well, I think that we're lucky because being a DPC, when change needs to be made, we can do it quickly. It's not like we have to get permission or go through a lot of rigmarole to make changes. And so we were in a really good position actually to offer. We never had to close, really. We continued to offer our patients service. We've continued to through this whole pandemic, and we were able to make safety changes and get our PPE and change the way we scheduled and the flow of the clinic actually really smoothly and easily to keep the patients safe, but to be able to continue to see them. We offer testing. We're out in the parking lot every day, swabbing people. We're helping to screen. We helped quite a few of the recipient patients who really didn't know what to do. A lot of them, the migrant farm workers and people that were coming down with COVID, didn't know how to access disability benefits, and they didn't know how to get back to work and with notes. And so we were really able to help them navigate things right from the get-go. So I feel pretty lucky that because of our DPC status, we really were able to just do it the way we wanted to,
For those who might be early on in their DPC journey in medical school or residency or exploring the world of DPC, I hope that they take that to heart, right? Because not only are your patients, I'm sure, so grateful, and they are absolutely blessed to have you guys in existence and to have you guys as their doctors, but also the fact that you were able to help them navigate through things that you would never get help with in a fee-for-service clinic. The doctors don't have time because there's no code for, I helped a patient understand or get to a particular page to download an application, right? So that's incredible. And like you said, everybody in this country, no matter who they are, should have access
I think the other
to that quality of care.
Of the DPC is the same-day scheduling module, where people are not scheduled way ahead of time. Interestingly, the pandemic something that has changed for us, is that our uninsured patients are now scheduling in advance. But previously, it was same-day scheduling. Benefactors would rarely be scheduled out a few months, but most of the time they'd make an appointment for tomorrow, today. And so we didn't, as Dr. Kiesel said, we didn't have to close, but even if we had been faced with that, we wouldn't have had to call 6 weeks worth of scheduled patients to let them know everything was delayed. So that DPC scheduling kind of thing is just incredibly advantageous, which is the reason I wanted to go into it in the first place. Was your own boss, and it's so much easier, so much more time with each patient, and so much easier in terms of the administration part.
Yeah, I think a couple other things that I thought were awesome that we were able to get FaceTime. We had, of course, we have that on our phones, but we were able to set up a station with Skype to offer that to anybody, recipient or benefactor, that wanted to do a virtual visit or over the phone visit. They didn't want to come to clinic. We were able to mobilize that. We already were doing that a lot, actually, as well. So it wasn't hard to get that going. And I think the other nice thing is that both Dr. Heck and I have quite a number of patients that either are homebound or in some kind of a facility. And we had the unique opportunity to be able to go, and at the beginning, we were actually testing some of those patients because some of the places didn't even have testing supplies yet. But I think also just some of these people are so isolated. They haven't been able to see their families. The places are on lockdown. And to be able to go in and see a patient and call the family and say, hey, I saw your mom and she's okay. I saw her and I examined her and she's fine. It was really, I think the families really appreciated that.
And when in a regular fee-for-service model, if a patient is being seen in a nursing home or in a facility, they, in most cases, don't know their doctor like you guys know your patients, right? With the way that your practice has pivoted with the pandemic, do you guys maintain a limit of how many patients you take? And has that changed because of the pandemic?
So that idea that we're limited in terms of the number of patients, we limit the number of benefactor patients, and primarily because they require that individual attention. They tend to be people who need more time than people out in the community who aren't necessarily, somebody who's paying that kind of money to be able to have better access wants more time with their physician. So that's the number that we limit. But on our uninsured side, we'll see as many people as we possibly can. We, for a while, actually, I remember in 2012, 2012 or 13, right before Affordable Care started, we did 5,000 free visits that year of uninsured patients. And we had 2 full-time doctors and 1 full-time PA and another PA coming in part-time. So we don't limit that except for availability. If there's a lot of benefactors scheduled on a given day, we may not have as much access for uninsured patients, but we don't necessarily limit that number. It's just we see as many as we possibly can.
When you talk about your schedule, I'm assuming that there are time slots that benefactors have to choose from. How does that work for the recipients in terms of scheduling, and how long are their appointments set for?
Benefactors do have access to our portal, which allows them to schedule their own appointments, and they can schedule as long of an appointment as they want, honestly. Most people don't schedule. They schedule somewhere between 15 minutes and an hour, depending on what they want to come in for. Sometimes we will choose the time if they, for example, call or text and they tell us what it is, we guess how long they're going to need. And so most of our schedule is open for that. The recipients, we try to put them into our schedules same day, if possible, wherever there are openings. And it's a similar idea. The appointments are probably 15 minutes to a half an hour, depending on what they're coming in for. And we just decide that based on what they tell us they need.
Gotcha. You guys mentioned that you're using FaceTime and Skype. Do you have that running through your EMR? And what EMR are you guys using currently?
Which is out of Austin, Texas. And we have to document in the actual electronic record whatever the results of an interaction with a patient are, whether that's in person or a FaceTime. And of course, there's the additive, I think it's -95 for if you have a 99213, there's a -95 for telehealth. But we have to actually do the documentation in the electronic record. It doesn't, the face-to-face program doesn't run through the electronic record per se.
When you mention the codes, is that because some patients will turn those codes into their insurances rather than you guys doing it? Or how do you use the codes for your patients?
We had people turn in codes to insurance to get something off of their deductible, but we haven't had that in more than 10 years. I think that option was removed, but I'm not entirely sure, not being well versed in insurance, but we haven't had to do that in quite a long time. So for the most part, it's only to document the number of visits and their acuity on our uninsured side to make sure that we are doing our 50% visits, the number of benefactor visits we want to equal or exceed that on our uninsured side.
And is that a goal that you guys set forth, or is that a goal that's helping you maintain the nonprofit
we applied
status?
For nonprofit status in 2003. And it's been an edict ever since. We've never been audited And now that I said that on the air, we probably will be, but nobody's ever checked into that. But we've exceeded 50%. That was something from the very beginning. We wanted it to be 50-50. And so we've been somewhere in the vicinity of 55-45 for recipients, uninsured folks, since the very beginning.
Going back to the beginning, how did you guys become a nonprofit? I hear the goals and the fact that you're reaching those goals with what you put forth to become a nonprofit, but how was the process of becoming a nonprofit for you when you guys started?
The IRS had never seen a model like St. Luke's Family Practice that combined DPC concierge care, as it was referred to in the early 2000s, with a beneficent model so that we could consider ourselves a 501(c), a nonprofit. And so we applied in 2003, opened in 2004, and people continued to make donations with an uncertain nonprofit status. And it wasn't until the summer of 2005 when Dr. Forrester and two of our early board members flew to Washington, D.C., sat down in IRS offices to prove to them that we were on the up and up. And there was also a Washington, D.C. tax attorney involved in this that made that happen for us. And it was retroactive to the very beginning, but it turned out to be a pretty tough process. And then, 6-7 years ago, we discovered that the way we were set up in the state of California, you could not be a corporation and practice medicine, which is unique to the state of California. So we had to reorganize. We're now I think it's a 510 social purpose corporation. So we still have federal nonprofit status and state nonprofit status as well, but under a different guise.
It's just incredible when people used to pay their doctor with whatever they had, whether it be chickens or money or whatever. And the idea that, like Amy Ostick once said, California is its own nation state it's pretty incredible what exists out there for DPC
agreed.
law right
and
now.
I'm not well versed in terms of the doing it yourself and billing your insurance yourself and that kind of thing. The amusing part at St. Luke's is that on the uninsured side, people feel so grateful that all the time we get fruit and nuts and people bring in boxes of candy. We'll have our migrant workers are picking cherries and we'll have a whole box of cherries sitting in our staff room. Everybody take a bag of cherries home, by golly, because can't let those just rot.
Absolutely. Yeah. We have a couple of wonderful women that cook us food and bring in food all the time. Yeah.
Absolutely.
It's a community. It's just beautiful. And when you feel a community spirit like that, I'm sure that leads to patients being more forthcoming with you and more willing to see you for something that they might have pushed off if it was a different clinic setting.
Yeah, I'm sometimes amazed at the distance people, we talked about the word of mouth thing. We have patients coming from as far as Bakersfield. I've had a patient come from the Napa area. People hear about us and they come from a long ways to get help.
And that said, given that I trained in part under Dr. Kiesel for residency and are familiar with that population, because people are coming from that distance, because you offer care to anybody and everybody, do you guys see people coming with significant pathology?
We still see significant pathology. It's not so much the kind of stuff that we all saw at county, but we still see people who have ignored for a long time because they couldn't get access, and the destructive results of ordinary things that could be cared for that get neglected because of a lack of care, long-term side effects of diabetes and high blood pressure. But occasionally you'll get one of those fascinomas walk in of somebody who got something really strange. Like I saw a woman a few weeks ago, was the third time she come in with some lesion on her abdomen that at one point last year we'd biopsied and had gotten a benign result, but it continued to grow. And we sent her down to a place in Bakersfield called Cirugía Sin Fronteras that does surgeries for cash, for cheap. And she had a spindle cell carcinoma. One of those things that, I've seen maybe 3 of in a 30-year career, comes walking in. Just somebody who's here working and afraid, doesn't want to go back to Mexico to have surgery because she knows she's not going to be able to get back across. And we were able to provide and get her to somebody who could make a diagnosis and get her treated.
Yeah, I would agree with that. I've seen quite a bit of pathology since I've been at St. Luke's, I think. We get a lot of follow-up out of different ERs, things that are maybe halfway diagnosed at an ER that we finish up, or even just things that walk in. A lot of what Dr. Heck is saying that have been ignored for a long time, but also just some really interesting infections and things that you wouldn't expect. It keeps us on our toes for sure.
Contact with somebody who has leprosy was at St. Luke's.
I know I had a case of scrofula, which I had never seen. So.
Okay, I take it back. We see great pathology.
You guys have people Googling like mad, I'm sure, right now. Because of the patient population in your clinic, especially those who are without insurance, how did you guys set up follow-up for those patients? You mentioned the surgery center down in Bakersfield, but locally, like for imaging, for labs, how do you guys get your uninsured patients care? Do you have the money that is from the benefactors also paying for those types of services?
Not exactly. We do have some agreements. Quest Diagnostics has been extremely generous in an agreement that we have with them for very low cost labs for patients. So labs are almost never an issue. That includes pap smears and biopsies, like skin biopsies or endometrial biopsies that we do in the office that can be done very inexpensively for these patients. And then as far as radiology, often our patients qualify for a charity care program through the Sutter system where they can get extremely low cost x-rays, CAT scans, all that kind of thing. But some of the other radiology offices also offer cash prices that are pretty competitive and doable. And sometimes they offer payment plans sometimes for the patients. Same with some of the local specialists will do a cash price for different consultation or certain procedures or services. They'll try to work with the patients to take care of them locally.
You guys have been open for quite some time compared to some DPCs, but Dr. Heck, in 2004, when you guys opened up until now, how do you guys find those specialists?
Over time, that specialist profile has changed as people have moved on through retirement or moved out of the area, or become restricted because of their affiliation with a different network. It basically, what your prior referral pattern established was, try that first. And if that person's not available, then start beating the bushes and see what you can find. For instance, gastroenterology. For a while, we had somebody here who was doing inexpensive colonoscopies for patients. That person stopped practicing in Modesto. And we ended up, I think it took us 5 or 6 months to find a local practitioner who could do it for a price that was moderately affordable for our uninsured folks. So it varies. In terms of other ancillary services, there was one place that we used for 3 or 4 years that they gave us great cash prices. And then they were bought by a bigger hospital network, and we couldn't use them at all for a while. And then that hospital network established a charity arm that people can apply for, qualify for, and then they get free imaging for a year. And suddenly we're back to referring to that center, because if we can get somebody on for a year, heck, we can do the x-ray of their arm and at the same time do that ultrasound of their abdomen to look for the gallstones. All of it free. It varies with time, and it depends what the local scenario looks like at the given time.
I want to digress because you had previously mentioned a board of directors. Can you tell us more?
So we have, since the very beginning, sought people with business experience in the community, and we've always tried to have several different disciplines on the board. Legal representation, accounting or numbers representation, somebody who's experienced with insurance, and people who have business experience, and often people who've been on other nonprofit boards, and so they can bring that experience to us. So I think we're in our 5th generation now of particular board members, and we've got a couple on our current board who've been there 4 to 6 years and a couple who are relatively new. But our board consists of usually 5 or 6 community people, and then Dr. Kiesel is on the board, and Dr. Forrester has been on the board and will continue as such. Under our reorganization, I'm no longer on the board. I'm the shareholder of a medical group that contracts with the board to provide care for patients. This was part of the reorganization stuff. Anyway, the board of directors are community people with business experience that have a fiduciary responsibility and make the numbers decisions. They'll determine the benefactor charges for a given year, and they'll determine the compensation for each of the employees. And they also give us advice about how to run from a business perspective, but all of the medical decisions at St. Luke's and equipment purchases are at least suggested by us, and we have permission to make purchases on our own if necessary up to a certain level, and then it has to be approved by the board for larger purchases. So that's basically the function of the board of directors.
For your board members, separate from Dr. Forrester and Dr. Kiesel, how did you find the
original
people who make up your board through
were
the years?
recruited by Dr. Forrester and myself as we were organizing and created St. Luke's, that of course was in existence before we opened our doors. It was a nonprofit, and it was in existence for a full year before the doors opened. And they were just people, we talked to them about the mission to them. After that, it was suggestions by board members about other board members who would be good possibilities. We'd invite them in, let them experience a board meeting and see if they were interested, and then seat them if they were interested. And that's the way we've done this now the whole time.
When you mention medical equipment, how do you guys go about getting medical equipment and supplies for your practice?
A lot of our equipment initially early on was donated by some really generous community members. Now the ongoing equipment generally we get because of donations that we receive from generous either benefactors or families that are just making donations, not necessarily as patients, just making a straight donation since we are a nonprofit. But in addition, we get lots of donations from patients and families of all sorts of supplies. Dr. Heck was talking about, he just had a patient come in and dropped off all sorts of supplies that a family member didn't need, gauze and wound care supplies. And sometimes we'll get medications, samples or unused medications donated, or just other pieces of equipment that someone might call and say, hey, we have an office closing. We need to get rid of all this stuff. Do you need any of these things? Do you want to come look and see what we've got? And they've been generous in that way in donating.
Again, community, right?
The generosity of this community, not just our benefactors, but our benefactors make up about 92% of our yearly collections, but also local foundations have been exquisitely generous over the years. The Gallo Foundation and the Foster Family Foundation, and some smaller local nonprofits like Mary Stuart Rogers and the Envirotech, all kinds of people who just feel compelled to give to what they feel like is a good mission. So those monetary donations help with equipment purchases. Each year we send out 4 or 5 letters to local boards of directors of other nonprofits that are out giving. They're basically foundations giving out money and saying, here's some equipment we'd like to buy, and would you be willing? This year, guess what was in that? A machine to test for COVID and influenza.
Yeah. We've also had some generosity from some philanthropic groups in the community. Seroptimus and another group called Omega Nu always donate. And sometimes it's very specific for women's health. So there are programs in California to get women mammograms, but some people don't qualify. And we always want to be able to take care of our women and get them their mammograms and their breast care and their pap smears. And so we do have a fund of money that if we can't get someone qualified on a program or they can't pay, that we never turn them away for those services.
Yes.
Thanks to those groups.
And do you guys approach groups like Soroptimist and Alpha Nu with a similar
and
letter?
Also, sometimes we'll go speak. Dr. Kiesel spoke to Soroptimist last year.
And Dr. Kiesel, when you spoke with Soroptimist, can you give us a flavor for how that went? Because if someone is listening and they are considering speaking to a community group, this might help them.
Yeah, they asked me to come and just tell a little bit about St. Luke's. So I had the opportunity to make a little PowerPoint presentation and give them a history of the practice and explain to them what kind of patients we serve, what our mission is, how we do it. I tried not to make the presentation too long, as inclusive as I could, but I wanted to leave a lot of time for questions because actually there were a lot of questions about it, which allowed us to put the word out in the community about the services we do offer for the recipients, for anybody that is uninsured, but also it seems like there's a good part of our community that doesn't even know that St. Luke's exists as a practice for anybody that could join as a benefactor as well. So it was an opportunity to put the DPC model out there for people that didn't know what it was. And I like to add in kind of the DPC flavor and kind of explain how it's a thing. The AAFP recognizes it and it's growing, and it used to be called concierge or boutique practice. And I don't really like that because I think it sounds a little bougie, a little exclusive, which it's not. Really, it's not at all. And when I explain our model and show people what the cost is, they realize that it actually is not something that is just for super wealthy people. Many people can join our practice and afford it and make it work for them. And I enjoy educating groups about this model of care, as well as letting them know that we do provide this service for the uninsured in the community.
And Dr. Kiesel, what types of questions specifically were you getting from the Soroptimist group, for example?
It is interesting. For as long as the practice has been in this community, a lot of people still don't know about it. So a lot of the questions are, wow, I've never heard of this before. I can't believe you've been here this long and I've never heard of you. But a lot of the questions have to do, can I use my insurance? Do I have to have insurance? How does that all work? A lot of it is that, about how the insurance situation works. People want to know about how much time can we spend with them? How do I make appointments? How can I communicate with you compared to at a big organization, which a lot of people are used to, a big Sutter or Kaiser managed care organization? They want to know how it's going to be different than that. I'd say that's mostly what they ask.
Had you guys, as part of your social media marketing campaign, had you guys also thought about doing like a general video to explain those things?
Yes, videos are something that we definitely want to start doing to explain the model a little bit more.
When you mention education of the community to make the community aware that you guys exist is huge, but also education of people who are potential doctors to join the movement. So with the residency being in Modesto, I want to ask, how do you guys interact with the residents, and do you have medical students who get exposure to St. Luke's as well?
Yes, so we are actually part of the practice management curriculum for the family medicine residency program. So they regularly send a resident as part of the practice management rotation to come spend some time with us, not to work for us, but to just learn about the practice and the practice model. So that's where they get their first exposure of us. And then we always invite them to come spend elective time if they want to, seeing patients. And we've had some residents come spend time with us. We also do teaching in the family medicine clinic, which kind of reminds them about us when they see us and reminds them to ask about St. Luke's. And then we definitely have medical students that come from all over that rotate with us, usually a month at a time. And interestingly, to get into medical school, it seems like many schools are requiring observation hours prior to applicants submitting their applications. And so we've had quite a number of students reach out to us because it's difficult now to find a spot to do that with the HIPAA laws and restrictions. A lot of offices won't take any kind of student that's not already in a medical school or in a residency program. So we've been able to help some undergrads get some exposure as well.
There are doctors retiring or clinics needing to expand, and patients wanting and deserving this quality of care that you guys are describing. So affecting the pipeline is a huge component of making sure that the movement grows. That said, because you guys are interacting with undergrads, medical students, and residents, amongst others. Do you guys have any suggestions as to how the pipeline can be affected for the future of the movement?
I think inviting people in and giving them a positive experience. And so many people, when I first got into medicine, were grousing about how medicine was changing. And here's a method that medicine is changing for the better, and making sure that residents and medical students, and frankly, we've even had high school students coming in, that they understand what the difference is between our practice and a regular practice, and understand the advantages, advertises DPC for the future, because it's a growing movement. It's something that will continue to grow in popularity and in abundance in the United States.
Yeah, and just to tag on to that, I think just us role modeling, not only the practice model, but just the lifestyle that can be with this model. Dr. Heck and I are two pretty happy people. It's a nice lifestyle. We don't make the most money of anyone around here in this community, but we're happy. And there's there's just a great ambiance in our office. There's a great spirit. There's a lot of laughter, a lot of joy.
There's a lot of birthday cake. There's a lot
of food. Yes. And I just think role modeling good work-life balance for these students is another way to make the DPC movement attractive and something that they're interested in.
You mentioned that St. Luke's has become part of the family practice management curriculum. How did that happen? Because when I was in residency, we did not have that opportunity. So how did rotating in your clinic become part of the curriculum for the residents?
I think that a number of different practices are involved in that curriculum around the community. Now, private practice is narrowed down. There's only a handful of private practices left in Modesto, I think. Yeah. And I think that St. Luke's was on it for a while, and then for some reason it went away. And I think that had to do with, I think it may have had to do more with the program, and when the numbers of residents shrunk down for a while, they were being pulled to different services so much they just weren't getting sent over to our office. But now I think we've just got it really set up and looped in, and Dr. Kern's the residency director, knows about us, and so she's just making sure it's on the schedule basically, and making sure they come over to us.
Dr. Heck, when you guys were starting out, did you speak to Dr. Broderick, who was the residency director prior to Dr. Kearns, or how did you guys develop that relationship from the get-go?
We were both graduates of that program, and of course, Peter Broderick was too. And we initially didn't have much room. We were in an 850 square foot office. So we had an occasional observer, but we didn't have the room that we have now in an office that, with our recent expansion, we're close to 4,000 square feet, but we were at about 2,400 when we first moved into that building, and had 2 extra rooms, one of which full-time PA occupied, but the other was just an observational room. So we could have residents in, let them observe what we do, and then let them start seeing patients. And that's why it became popular for a while. We were not just doing family practice management rotation, where they come in for a single day and learn about our practice, but we had a couple times people come in and do a 2-week rotation through. I think even one came for 4 weeks, about 2 half days a week. Our office basically supplemented what they were doing in the family practice clinic. Because of our previous relationship with that residency program, I think that's how it happened. And as Dr. Kiesel said, it dropped off as relationships changed and the leadership changed. Interestingly, I think it picked back up when Dr. Kiesel was the associate director. She was the deputy director at the family practice residency program for a while.
Yes. Having that connection, I think, has definitely helped get it going again. Let's put it that way.
Yeah. I asked that because if a DPC were close by to a residency, which there are a number of DPCs that fit that category, I wonder if there's any advice that you guys could give as to how to approach residency, right? Because just like how you guys have it set up, there are a number of residencies that are incorporating DPC options into their curriculum that I've learned about, which is awesome. But for those who are just like starting a DPC from the ground up, starting a relationship with a residency, Do you guys have any advice as to how a practice could develop that type of relationship?
Well, I would say definitely reach out to the program director or associate program director, or if there's someone that coordinates the clinical rotations for the residency, to put your name in the hat type of thing. Let them know about you, let them know about your practice. Most residencies have some day or certain times where didactics are happening, and they may want to request a slot to give a lecture about their DPC practice, to come over and give a lecture to the residents. And then at that time say, hey, I'd love to have people rotate with me. Give me a call. I think practice management is part of the curriculum of all family medicine rotations. So they have to be doing some kind of practice management. And so to offer it that way, hey, I'd like to be part of your practice management, whatever experience you're offering your residents, we'd like to be part of that, and just put yourself out there. Contacting chief residents to get the word spread around, especially if you're willing to have residents come rotate at your practice. Going to the residents themselves is always really good. I think most places would be really open to, and would love it if a practice, was open to having the residents come and learn.
Absolutely. And I think it's a much easier sell now because DPC is, again, a growing part of family practice, of family medicine in general, and particularly AAFP is much more strongly emphasizing DPC and the DPC type of practice.
For us as family doctors, the value that we bring when we finish training is incredible, and patients are not really aware in a lot of cases of what we offer. Like you guys are saying, the community isn't aware of your practice. Patients don't realize that we can, as well-trained family physicians, take care of a lot of things. 85 to 90% of medical issues that are not life-threatening, we can manage in an outpatient clinic.
Absolutely.
Yeah.
Amen to our residency, because I felt absolutely prepared to practice in a rural environment. So thank you to our residency, and thank you to you, Dr. Kiesel, for that, for sure. Dr. Heck, you mentioned your space and how it's developed over time. And recently you guys had an expansion. So can you tell us about your space, how you came to be in your current space, and a little bit about your expansion?
We started in a much smaller space, but one of our board members in 2009 said, "You've outgrown this place," because every day we had people streaming out the door into the lobby of this building where there were multiple medical offices. And he looked for a space that we could have. Originally, we thought maybe freestanding. The space we're in now has been a pediatrician's office. I think the building's been there for 60 years, but we were very well blessed in that the owners of that building let us move in and have a low-cost rent, and it has increased only slightly over time. They also, interestingly, that family became patients of ours, and we occupied with the idea that initially we'd have just those 4 rooms we talked about, one for Dr. Forrester and I, a PA, and then a room for residents or observers. But it became clear that we wanted to grow it and add a 3rd doctor. And Dr. Forrester and I had long sought after the services of Dr. Kiesel, who's been a talent, grew up in this community, and 20 years out of residency, and just a smart cookie. So anyway, we finally were able to convince her in the early part of 2018 to join us. And after she joined us, she occupied that 4th room. We knew immediately we had to proceed with plans to expand. Those had actually been started in 2014, but put on hold because at the time, it was maybe a little earlier than that, because the bids we got, we had collected some money, and then it turned out we couldn't proceed for a couple of reasons. By the time we were ready to proceed, the bids were way under, or what we had in the bank was way under what the bids turned to. And we waited a bit and sought some more community funding, but we were finally able to proceed with that starting, I think, in early 2019. And gosh, when did we finish that, Aaron?
Christmas 2019.
Yeah, that's right. So it's been through the planning of earlier board members and then the generosity of local foundations that we were able to get the expansion part done. And then the fact that we've got the generosity of benefactors and foundations to continue, it didn't increase our rent at all. Our rent at the time included this floor space. And so our rent wasn't increased. It just was the cost of actually doing the build out. And one of our current board members is owner and chief operating officer of a local construction company. They were gracious enough to help us out. So again, more generosity. Usually this company doesn't do any builds. I think he said we usually don't shoot after anything under $2 million. And we were way under that. Generosity from multiple sources here in the community made it happen.
I want to turn the conversation to collaborations. Now, you guys have helped different clinics open over the years, specifically Our Lady of Hope in Madison, Wisconsin, and St. Joseph's Primary Care in Raleigh, North Carolina. I wanted to ask, how did those collaborations happen? And can you give us some details as to what type of collaboration you had with those?
Those people sought information from us, primarily Dr. Forrester, who had gone to AAFP and given lectures, Catholic Medical Association, and talked about at the time it was known as the Robin Hood model. And then those people sought information from us about our particular type of model of combining DPC with a nonprofit beneficent side. And so we didn't charge anything, just sent them all of our paperwork and gave them all the details about how to set up with the IRS. And both of those places, in Madison and in Raleigh, had really no trouble getting IRS approval.
Do you guys have any tech or tools that you use and love that you can't go without in your clinic?
We love our electronic medical record, the EMD's system, just in general. And then we use some, I think, ones that everybody uses, UpToDate, Hippocrates, some of the different calculators.
Mm-hmm. We used to buy Harrison's, the updated issue of Harrison's every 3 or 4 years, and now it's all on UpToDate.
Dr. Kiesel, you were using Essential Evidence. Are you still using that?
You know, I'm not using it quite as much as I used to. I still have it. It's so nice because it's so inexpensive. And it's also just a quick, it's like UpToDate, like slimmed way down and I don't know, in a concise form of whatever your clinical question is. So I'm not using it as much just because I think I'm not teaching evidence-based medicine as much anymore. I should use it more, actually. It's nice, but I still love it.
Good to hear, because I had not known of that resource prior to training with you. What advice can you guys give to people entering the DPC space?
I've had students from high school on up to residency ask, do you feel like you made the right choice? And I can't ever remember a time when I didn't want to do this. So I've been very well blessed to be able to get into family medicine, but I think DPC has been the ultimate practice of family medicine. Much more time with each patient, getting to know multiple generations of the same family, viewing all kinds of incredible pathology and feeling adequately trained to treat that. To me, DPC is the best combination of family medicine.
Yeah, I would totally agree with that. It allows you to practice full scope family medicine and to use whatever special skills or interests that you have. I think each of us in the practice has some certain things that we're particularly interested in. Dr. Heck has a bunch of things he's really good at. Dr. Forrester was our derm guru. And I like women's health, and we can all do that as well as everything else. And we learn from one another, I think. So advice-wise, I would say stay true to the profession. If that's what you're looking for, is to practice full scope family medicine, this is a great way to do it. Definitely, if you can, get with some other like-minded people that you enjoy being with all the time and that you can learn from each other and work well together. Prepare to probably make less money. And I know that's difficult in this day and age when medical school is so expensive and there's a lot of loans afterwards. But I think if it's what you want and it's what you're passionate about, you can make it happen. So just stay true to that, because I think the trade-off of a happy life makes everything worth it.
On that note, what is the best way for others to reach out to you?
I would say by email addresses.
Mine is drh at stlukesfp.org. And Dr. Kiesel's is DRK. And any of those emails, we will be able to get back to you within 3 or 4 days. And that's assuming you write on a Friday and we don't see it till Monday. Otherwise, it'll be next day.
Yeah.
Perfect. Thank you so much, Dr. Kiesel and Dr. Heck, for joining us today.
Thank you so much for having us.
We appreciate the opportunity to talk about this.
Next week, look forward to hearing from Dr. Jake Much, Dr. Christina Much, Dr. Lauren Hughes, and Dr. Dipti Munkour as they share their stories 1 year later. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Concepcion.